Hi, everyone. Thank you for joining our Debbie's Dream Foundation webinar series. Today's webinar will feature Dr. Zachary Brown, who will give a presentation on the evolution of surgical management of peritoneal metastasis from gastric cancer. I am Jen Higgins-Spires, Programs Manager for Debbie's Dream Foundation, and I will be moderating today's webinar. Thank you to our generous sponsors for making today's program possible. Platinum sponsors Bristol Myers Squibb, and this program was made possible through an independent grant from Merck and Company Incorporated. Thank you also to our silver sponsor, Amgen. First, I will share information about stomach cancer and Debbie's Dream Foundation. Then we will hear a presentation on the evolution of surgical management of peritoneal metastasis from gastric cancer, and a question and answer session will follow the presentation. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is a leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate of 36% in the United States. Many patients are asymptomatic during the early stages of stomach cancer, leading to late diagnosis. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiesdream.org. Pictured here is Debbie Zellman, the founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in April of 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many recurrences. Unfortunately, Debbie passed away on December 23rd, 2017 at the age of 50 after a 9.5-year battle with stomach cancer. As an organization, DDF continues her important work and legacy. In a few short years, DDF has achieved many great milestones. We have about 32 chapters across the United States, including Canada and Germany. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We also have provided more than $2 million in research grants to date. Patient advocates come together each year at our annual Stomach Cancer Capitol Hill Advocacy Day to secure funding from the Department of Defense's peer-reviewed cancer research program, which allocates funds for stomach cancer research. Earlier this month, on February 5th through 7th, we traveled to Washington, D.C. with more than 150 advocates and held more than 200 meetings with lawmakers to inform them that we need more funding for this deadly disease. We are proud to say that this year was our largest turnout yet. We hope you'll join us next year as we let Congress know we need a cure. Please note you can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions at the conclusion of the presentation as time allows. Zachary Brown is an assistant professor of surgery within the Division of Surgical Oncology at NYU Langone Health in the Peritoneal Cancer Center. Dr. Brown has a special interest in treating patients with advanced or metastatic cancers originating from the stomach, appendix, colon, rectum, small intestine, and peritoneal surface. He is a board-certified oncologist and an expert in treating patients with a method known as cytoreductive surgery and hypothermic intraperitoneal chemotherapy. Dr. Brown believes in personalized care and empathizes informed decisions. He inspires hope, empowers patients beyond their disease. Dr. Brown thrives in multidisciplinary teams at NYU and is committed to comprehensive cancer care. We will now begin the presentation on evolution of surgical management in peritoneal metastasis from gastric cancer.
All right, great. Thank you so much for that introduction, and I really appreciate the opportunity to talk to everyone today. So, as was said, I'm a surgical oncologist, and one of my main focuses in my clinical practice, as well as my research initiative, is to treat patients with peritoneal surface malignancies. Specifically, one of my main interests is to treat patients with metastatic disease or disease that has spread from the primary organ to the lining of the abdominal wall. So we're going to talk a little bit about today is how we've treated these patients before and how we can kind of go through and improve the care of the patients with peritoneal surface malignancy secondary to gastric cancer. So I have nothing to disclose. So this is a kind of an outline of what we're going to talk about today. We're going to overview of what are peritoneal metastasis, why to do surgery on those patients, and what is intraperitoneal therapy, who are candidates for this, and what are the current treatment strategy and paradigms we're trying to do to improve outcomes of these patients. This is a saying that kind of holds true to a lot of surgical oncologists, is biology is king and selection is queen. So everything that we do as surgeons, we always have to think about what we're doing, and not only for the patient, but what is the underlying tumor biology, or how is the tumor going to respond to whatever we're going to do. And truly in treating patients with gastric cancer and this problem with peritoneal metastasis, I believe it's all about selecting patients and really trying to prove biology, and that what I'm going to do is going to really help you in the long run. So in general, peritoneal malignancies are a significant challenge to providers and to patients, and it's synonymous when you hear the term, and a lot of times you hear peritoneal carcinomatosis, which is basically tumor that has spread or involves the peritoneum and is basically spread throughout a wide portion of the abdomen. And it really encompasses a wide range of different cancers. A lot of times you can hear about primary cancers coming from the peritoneal surface, such as mesothelioma. A lot of times you hear about mesothelioma on TV, and you hear about in the commercials about smoking and asbestos exposure. They can happen from the lining of the chest wall or the lungs, the pleura, but it can also happen in the abdomen and the peritoneum. And then you can have secondary disease of the peritoneal cavity, or metastatic disease, a disease that has started somewhere else and has spread there. Commonly, when we think of this, we think of patients with gastric cancer, appendiceal cancer, colorectal cancers, or ovarian cancers from GYN malignancies. And unfortunately, compared to other metastatic disease sites, patients with peritoneal metastases do worse. So this is a study that was done focusing mostly on patients with colorectal cancer, where they looked at survival from patients that have disease that had spread to either the lung, the liver, or the peritoneum. And unfortunately, patients with disease that has spread to the peritoneal cavity tend to do worse than other metastatic disease sites. There's several theories of why we believe that, and one of that is we think that the systemic chemotherapy, or chemotherapy that we traditionally give through the IV, does not penetrate as well into the peritoneum, and it's almost excluded from getting as good of a treatment as, say, patients with disease that has spread to the liver. And that often results in worse survival. So if you look at this study, the lung, the median overall survival is about 25 months compared to the liver, with a survival median time in the middle of 19 months, and the peritoneum was only 16 months. And so what is the real clinical problem here? Especially with gastric cancer, peritoneal metastases are very common. Peritoneal metastasis can be as high as 30% of patients when they initially present with gastric cancer, and up to 15 to 50% of patients can develop peritoneal metastasis at the time of recurrence or when the cancer comes back. And the survival of this is poor. In colon cancer, if left untreated, we think that the median survival is only about 5.2 months. In gastric cancer, is really only about 3.1 months. In pancreas, even worse at 2.1 months. And again, the reason why we think that the survival is so poor is the systemic chemotherapy really has limited penetration to the peritoneum or to the abdominal cavity. So why does this happen is we think that this is a different route of metastasis than other ways that cancer spreads to either the lymph nodes, the lung, or the liver. We think that it's basically a shedding event where tumor kind of gets dislodged from the primary cancer and then migrates or breaks free and is able to spread throughout the peritoneal cavity or throughout the abdomen. And then different changes occur within the tumor itself, and then is able to lock into the peritoneal surface or the surface of the abdominal wall and kind of establish itself there as a metastatic disease site. So because of this, certain things that we do in the workup of gastric cancer really focus on finding patients with peritoneal metastasis. So part of course, the clinical workup for gastric cancer is a history and physical exam, get to know your patient, symptoms they may be having, things that you might be able to do to help them as you're working them up. Endoscopy with a biopsy, so always get tissue and know what you're dealing with. And then endoscopic ultrasounds are to know the T stage. So when we talk about T stage, is how far that tumor is penetrating through the wall of the stomach, so we know how deep it's going through. And then of course get our imaging with either a CT scan, a CAT scan, or a PET scan to know if there's any sites of spread that we can see outside of the stomach, such as the liver, the lungs, or sometimes you can see it in the peritoneum. But what happens sometimes with the peritoneal cavities, you really can't see these metastases on cross-sectional imaging. It's because of what's called a occult disease. And how I like to explain it to my patients is that these metastases aren't generally bulky, where it's like a nice ball that you can see in the abdominal wall. Sometimes they form sheets of tumor or very small deposits that we really can't see. So in general, what we recommend is patients that have a certain T stage, we actually do an additional surgery separate from an actual gastrectomy or before we take your stomach out, or to do chemotherapy, and we call that a diagnostic or a staging laparoscopy. And at that time, we do peritoneal washings specifically to look at this. Because we know that if we take out the stomach in the setting of metastatic disease and we leave the metastatic disease behind, there's really no difference in survival. So what we try and do is to treat you and not just the cancer, and to really know the risk and benefits of what's going to happen. So this was a study that's called the Regatta trial from 2016, and they took patients and they randomized them to chemotherapy alone or chemotherapy plus the gastrectomy without removing any of the metastatic disease. And we saw that there's really no benefit of doing a gastrectomy in these folks. So this is really why I want to try and find and see if any disease is spread before we go ahead and take the stomach out. But what we know is that diagnostic laparoscopy is fairly underutilized. And this is a study that I took a part in where we looked at patients with gastric cancer from a large database series. And only about 13% of patients had a diagnostic laparoscopy, but that has increased over the years and has made its way into the NCCN guidelines, where we really want to look for patients with peritoneal metastasis, because even if you cannot see the metastasis, but you know that there's cancer cells in the peritoneal fluid that you do during the washings of the operation, that those patients still do poorly and should not get a gastrectomy. So what is the goal of surgery in patients with peritoneal metastasis? So patients with peritoneal metastasis should all get systemic chemotherapy up front, because we really want to know what the biology of the tumor is and then what's going to happen, because my number one fear as a peritoneal surface malignancy surgeon is to put a patient through a rather large operation and then find cancer has spread somewhere else, and what I did really provided no benefit. So generally always start off with systemic chemotherapy, and then we could talk about surgery, intraperitoneal chemotherapy. And when we talk about that, we want to talk about, is this a treatment strategy or is it a palliation strategy, or are we trying to control some symptoms? And in some folks that you think about it, that everything that we do is surgery in these patients is palliation. But I think there's strategies that we can use to really try and provide treatment and encourage long-term survival. So who are candidates for surgery with gastric cancer and peritoneal metastasis? So again, biology is queen, or is king, selection is queen. And the rest of the quote that often that Blake Katie talked about is the technical details of the surgical procedures are the princes and princesses of the realm who frequently try to overthrow the powerful forces of the king and queen. So when we talk about doing surgery on these patients, again, it's all about biology, patient selection, and then what we're going to do really can't overthrow the biology of the tumor. So in that context, how peritoneal metastases present is widely varied. So you can see in the top left-hand corner, that's basically microscopically occult disease, and you can't see it, and you can only see it in the washings and under the microscope. You can have rather limited disease, as you can see on the top right, to full-blown carcinomatosis with wide involvement of the peritoneal cavity, as you can see in the bottom two panels. So it's all about selecting the right patient for the operation. So in general, candidates for cytoreductive surgery and HIPEC, or to remove all the tumor, we have to take into account the histological characteristics of the tumor and how the tumor is acting. How does it look under the microscope? Are there poor features to it? How fast is the tumor growing? How fast is it progressing? Is it penetrating into organs, meaning is it invading into other structures, or is it pushing them to the side? All of this matters when we talk about the tumor biology. And then how is the patient responding to systemic chemotherapy? If you're getting chemotherapy through the IV and the tumor keeps progressing, either locally or throughout the abdominal cavity or to other organs, then in general, you're probably not the ideal candidate for this operation. You're likely not to benefit. We also look for is a single metastatic site. So think of the sites of metastasis as generally 3 different spots: the liver, the lung, and the peritoneum. And typically with gastric cancer, I only allow the peritoneal metastasis because really it's all about patient selection. And really my goal is to remove all the tumor. So this is a study that looked at how much tumor you remove. And if you remove all the tumor, as you see in the blue line, those patients do better. So it's all about, again, selecting the patients and can you remove all of the cancer from the patient. Another important thing is that cytoreduction does not mean debulking. This is a common thing you hear is people will say, I'm going to get my tumor debulked, or can't you just debulk it? So in patients with gastric cancer and peritoneal metastasis, or gastrointestinal cancers in general, our goal isn't to take out some of the tumor. In general, our goal is to take out all of the tumor in the abdomen, and that's the whole goal of this surgery, is to perform a complete cytoreduction, or to remove all of the tumor, because we know those folks do better. And this is not a new concept. Cytoreductive surgery, or removing these peritoneal metastases, was first conceptualized about 100 years ago by Dr. Miggs, who provided the first evidence that if you take out tumors from the peritoneal cavity in patients with ovarian cancer, these patients do better. And this was really developed further in the 1980s by Dr. Sugarbaker, who was looking at patients with gastrointestinal malignancies and to perform a cytoreductive surgery in HIPEC. So what is cytoreductive surgery? So cytoreductive surgery is removal of all visible tumor from the abdomen. There's different scores that you might hear. One of the most common things is talking about the peritoneal carcinoma index, or peritoneal cancer index. And that's a way of physicians or surgeons talking to each other to know how much cancer is inside the abdomen. So we divide the abdominal cavity into 13 regions, 9 of the abdominal wall, and then 4 involving the bowel. And you basically do a scoring system where you look at how much tumor is in different parts of the abdomen and you add it all up. And it's a score of 0 to 39, 39 being the most tumor that you can have. And in general, for gastric cancer, in order to perform a cytoreductive surgery in HIPEC, we like to see the score less than 10, ideally less than 7, because we know those patients do better. And then we talk about the completeness of cytoreduction score, or how much tumor you leave behind. In general, we consider a complete cytoreduction as a CC0 or a CC1, or any tumor that's less than 0.25 centimeters or 2.5 millimeters. Anything bigger than that we leave behind is considered to be an incomplete cytoreduction, and that's one of the things we look for when we assess your ability to be a candidate for this surgery. Is can we take everything down, every tumor out that's over 2.5 millimeters. So the technique for cytoreduction, it's a multi-visceral organ resection, or as I tell my patients, when you consent to a cytoreductive surgery, you basically consent to having all tumor removed, no matter what the extent, and kind of have to use my judgment if it's worth doing that. So it could involve a multi-visceral organ resection such as the stomach, small bowel, colon, rectum, pancreas, spleen, parts of the diaphragm, the surface or parts of the liver, the uterus, the ovaries. And generally, I always resect the omentum. There was a study done that looked at if you have the fat covering that lies off the colon that covers your abdominal cavity, that if we look at that under the microscope, no matter if there's tumor in it or not, if there's peritoneal metastasis present, generally there's always disease present within the omentum. And then peritonectomy as needed. So the picture on the right-hand side, that's the lining of the abdominal wall that's involved with tumor. That's the peritoneum. So I take that off as needed in order to get down to a complete cytoreduction. We're able to get all the tumor out. So the one thing that we need to determine is, can you have a cytoreductive surgery? Could we take all of the tumor out? Some of the things we look for to determine resectability is high burden of disease. So are we able to complete cytoreduction? And then what we have to take out and what needs to be left behind. So if there's diffuse small bowel involvement, we can't take out the entire small intestine, or going down the mesentery if it's penetrating through. We can't take that all out, so you wouldn't be a candidate for a cytoreductive surgery. And then major involvement of the porta hepatis, or where the big blood vessels go into the liver. That could be a very difficult area, or parts behind the liver, to completely be able to safely cytoreduce, so that might make you ineligible for a complete cytoreduction. So then when we do the diagnostic laparoscopy, what's the goal? Part of my goal is to determine what is the PCI, or how much tumor, again, is within the abdomen, going from a score of 0 to 39. And we know that based on multiple studies that a PCI of 20 greatly decreases your likelihood of being able to get a complete cytoreductive surgery, no matter what the tumor histology is. So if it's colon, rectum, or stomach. But in general, we try and select patients that are going to do best from this therapy if we're going to put you through a big operation. And then to determine resectability, again, what is the burden of disease? If there's a diffuse small bowel involvement, major involvement of the porta hepatis. And in general, for other histologies, I like to preserve the proximal third of the stomach. But with gastric cancer, that's difficult because often these patients either had a gastric surgery, or they require a significant portion of their stomach to be removed at the time of cytoreduction in order to get all the tumor out, including the primary cancer. So all of this matters. So the extent of disease and the completeness of cytoreduction matters. So this was a study performed in 2010. And what we know is that when patients have the least amount of disease, as you can see on the left, if your PCI is less than 7 or 0 to 6, you do better. The more disease you have in the belly, you tend not to survive as long. And that goes hand in hand with the completeness of cytoreduction. So are you able to get all the tumor out, As you can see in the blue line on the right, all those patients do better compared to patients where tumor is left behind. Those patients tend not to live as long. This is showing the same thing again in a different study, where again, the higher amount of disease, the higher the PCI on the left, the less likely you are to have long-term survival. And the more tumor that you can get it out safely, those patients all do better. So important variables to consider when doing a cytoreductive surgery and intraperitoneal chemotherapy is completeness of cytoreduction. So when you're doing your cytoreductive surgery, being able to get down to a CC0 or CC1, and what is your starting PCI? So how much tumor is there when you start off with? And then when we talk about the intraperitoneal chemotherapy, we want to talk about the temperature, the duration, what we're using, and the technique. So who are candidates for this surgery? What I like to think about is, what is the extent of disease? Is your disease resectable? What is your overall health? Are you eating okay? Are you losing a lot of weight? Are you really struggling trying to keep up with everything that's going on? And then what is your underlying tumor biology? So when you put this all together, that's how you get who's a candidate for this operation. So then when we talk about intraperitoneal chemotherapy, you're going to hear a lot of different words of what is being used. So the first one is HIPEC. That's what I mostly do. So HIPEC is heated intraperitoneal chemotherapy, or we warm up the chemotherapy and we pump it through your abdomen at the time of the operation. So after all the tumor is out, after the cytoreduction is complete, we do a heated intraperitoneal chemo for you. You also can hear of NIPEC, or normal thermic intraperitoneal chemotherapy. In general, this is done after the operation. So the operation is complete, you're closed up, or it can be done in the neoadjuvant setting or before cytoreduction in order to get you down and control your tumor biology. And this is non-heated intraperitoneal chemotherapy. And this is commonly given as HIPEC, or early post-operative intraperitoneal chemotherapy, just different words. And then one of the newer strategies and one of the newer things coming along is HIPEC, which you may hear of, is pressurized intraperitoneal aerosolized chemotherapy. So this differs from HIPEC in that it's an aerosolized chemotherapy. So it's air, and the chemotherapy isn't dissolved in a water or a saline solution. So why do we do this? So we know that, as I said before, that the systemic chemotherapy, the chemotherapy we give through the IV, doesn't penetrate well into the peritoneal cavity. But what we found is that if we use certain chemotherapeutic agents, we're able to keep them in the intraperitoneal cavity, or when we wash the belly with them, that chemotherapy agent stays within the abdominal cavity, attack locally within the tumor, without a lot of absorption into the bloodstream, where it gets systemically and can cause other problems throughout. So this shows that when we do this is from Dr. Sugarbaker's group, who we talked about before, is that if we heat the intraperitoneal chemotherapy, we can increase the peritoneal concentration with limited systemic absorption. So again, keep it locally to have it act on the tumor within the peritoneal cavity. So when I talk about cytoreductive surgery and HIPEC, I almost think of it as two separate procedures that happen during the same operation. So cytoreductive surgery, again, is removal of all visible tumor, and HIPEC is that warm chemo bath to treat the tumor that we can't see. So why do we heat the chemotherapy, and what is it? So we think that when we heat the chemotherapy up, we can actually increase the penetration into the tumor cell. That we think that we can get it to penetrate about 2.5 millimeters. So that goes back to what we talked about before with the completeness of cytoreduction, where the chemotherapy can help get rid of the tumors that are small and that we can't see, or the microscopic disease as well. It can also alter cellular metabolism, increase tumor penetration, and that we try and pick drugs that act locally, have a lot of systemic absorption. So this is not without controversy. This is a study for colorectal cancer. It came out several years ago called Prodige 7. And what they actually looked at for patients with colorectal cancer is they looked at the benefit of HIPEC, or the intraperitoneal chemotherapy, over cytoreductive surgery alone. So what they did is they took patients and they all got chemotherapy up front. And then they either took all the tumor out, and that's all they did as part of the operation, or they took all the tumor out and then they went ahead and they did the HIPEC intraperitoneal chemotherapy. In this patient population, they didn't find any survival benefit, or they didn't see anybody live longer in patients that received HIPEC compared to the patients that just had cytoreduction alone. Several things in this study that we tend not to do in the United States. So in this study particularly, they use oxaliplatin chemotherapy, which a majority of the patient received beforehand. They received it through the IV. So there's some concern that could that have led to some immunity to that chemotherapy when it's given through the belly. And also what they did was they used oxaliplatin for 30 minutes, and we tend to perfuse our patients with gastric cancer with mitomycin C for 90 minutes. So it's a different chemotherapy for a different time frame. Yet there's a lot of controversy over doing this for colorectal cancer. But what about for gastric cancer? So there's actually a study looking at this that was published back in 2011 where they took patients and they looked at them for cytoreductive surgery alone, for cytoreductive surgery and HIPEC. Now, HIPEC for gastric cancer in this study, they used a combination of chemotherapies. They used mitomycin C and cisplatin, both through the belly. And what they found is that when you did cytoreductive surgery with HIPEC, you actually improve the disease-specific survival from 6.5 months with cytoreductive or surgery alone to about 11 months with the addition of the HIPEC. And again, what they saw was, of course, that the complete cytoreduction improves outcomes. So current treatment strategies, what we know is that the survival for patients with peritoneal carcinomatosis from gastric cancer is poor. It's rather dismal, with a mean survival only 4 to 7 months. And that when we do cytoreductive surgery and HIPEC on these patients, we really see an increase in that survival to about 11 months compared to cytoreductive surgery alone, 6.5 months. And so what we tend to think about, and how I like to think about it, is that one dose of doing a HIPEC on these patients, similar to what we do in other disease states such as colon or appendix cancer, is that really enough, or do we need to treat the peritoneal cavity multiple times? So the question is, can we do normal intraperitoneal chemotherapy, the HIPEC, and do that multiple times during the course of systemic chemotherapy through a catheter into the abdominal cavity or into the belly? Or can we do multiple HIPECs before we go ahead and take the tumor out, or sequential HIPECs? So in terms of HIPEC, this was a study done in Asia, the Phoenix GC trial, where they looked at just that, of giving intraperitoneal paclitaxel, or a different type of chemotherapy, along with IV paclitaxel and S1, or with 5-FU derivative that's commonly given in Asia. S1 is not available in the United States. And they looked at that versus IV cisplatin and S1 alone. And what they found is that there was a slight increase in, although it was insignificant, in median overall survival with the intraperitoneal chemotherapy, but they got patients up to 17, almost 18 months in using sequential IV and IP paclitaxel. There's also an ongoing study. This is Dr. Senthal's group out at UC Irvine in California, where they're looking at giving repeated paclitaxel normal thermic intraperitoneal chemotherapy along with systemic paclitaxel and 5-FU. And what they're looking at is if they can get patients down to a PCI where they feel like they can resect them, and can this improve survival. So results of this study are still pending. This is still ongoing. But this is one of the current treatment strategies we're thinking of, is can we treat multiple times the peritoneal cavity in order to get patients down to an area where we can cytoreduce them or really prevent the cancer from coming back. There's also laparoscopic HIPEC, or a minimally invasive HIPEC. This is done out of a group from MD Anderson, where they did a study in 2017 looking at laparoscopic HIPEC without cytoreduction, so just perfusing the abdominal cavity with chemo without taking any of the tumor out. And then if the peritoneal disease resolved or got better, they would be able to do a gastrectomy. And now this study allowed for repeat HIPECs. And again, 6 patients out of this had microscopic disease, or only cytology positive disease, but they're able to see that 37% of patients were able to have disease clearance, and 26% were then able to follow up and get a gastrectomy, and they're able to get a median overall survival, these patients, of about 30 months from the time of diagnosis and 20 months from the time of the first HIPEC. So that's significantly better than what we've seen before. But again, these patients in these studies are very highly selected, meaning that they don't just do this to anybody, and they really want to get the patients, again, biology is king, to have the best results. So they also did a follow-up study where they looked at gastrectomy with cytoreduction and HIPEC. All patients received systemic therapy up front and at least 1 laparoscopic HIPEC with a combination of mitomycin C and cisplatin. Again, all these patients are very, very highly selected. 80% had a greater than 8 cycles of chemotherapy. 25% had a PCI greater than 3. So again, a lot of patients, very limited disease burden, and they were able to get a median overall survival of 22 months. So the new thing kind of coming out, that what a lot of investigators are looking at, is to use HIPEC, or the pressurized intraperitoneal aerosolized chemotherapy. And this has been done more in Europe and is making its way to the United States. And this is a study where they looked at HIPEC database, so they looked retrospectively going back in time, and they looked at results of HIPEC with cisplatin and doxorubicin, so 2 other chemotherapeutic agents. And they looked at 163 HIPECs done in 42 patients. So patients received multiple iterations of this with a median PCI of 17. So much, much higher than the study that we just looked at before. And they were able to get an overall survival of about 19 months. And out of this group, 6 patients were able to get resectable and were able to then undergo cytoreductive surgery and HIPEC. So with this, they use both modalities, where they're trying to use the aerosolized chemotherapy to get them down and then able to become resected and be able to follow up with a HIPEC procedure. So again, I think what this all burns down to is selection is really key, that the PCI matters. So where are you starting at? How much tumor is there? You want to select low burden of disease to resect, so not to just say anybody's eligible for this, but to really kind of test the biology and try and get patients down. And does downstaging the tumor matter? Is that if we're able to do repeated intraperitoneal therapies, does that help in being able to get the PCI down? Because again, a PCI less than 7 we know does better, but the question still is, at least in my mind, is it PCI where you start, or is it the PCI where you can get them down to before you do your cytoreductive surgery? And then just a little bit of selection is key, because can you actually do this, like I said before, therapeutically or palliative, meaning that are you just doing this like a intraperitoneal chemo or method to try and control symptoms, or ascites, where this is a study where they looked at trying to do it in the palliative setting. And you can see those patients did much worse than patients that were selected to do this as a therapeutic setting or an adjuvant setting where things were removed. So really the takeaways, I think, from the talk today are peritoneal metastasis from gastric cancer are unfortunately very common, and survival from this situation is unfortunately quite poor. However, treatment options are available. And I think one of the things is to look for a clinical trial, or look to a treating center that is able to offer this, because again, it's really all about selection. You want to have someone that's going to select a procedure that's going to be most beneficial to the patient, not just do it because it can be done. And again, cytoreduction is not debulking. So there's no role for this if you can't take all the tumor out, or if the tumor burden is really high. You're probably this is not an operation for you, but some patients are, and some patients can get long-term good results. And again, I think this is the biggest takeaway is biology is king. Gastric cancer has a rather aggressive biology, and that if we're going to do this and treat patients with metastatic disease, we have to treat them appropriately, and we really have to select the right people to get this. So I'm happy to take any questions. Thank you everybody for your attention. And this is my contact information. If you need me, I see patients throughout the Long Island and the New York City area.
We thank today's speaker, Dr. Zachary Brown, for taking time out of his busy schedule to present for us. And so please make sure you put your questions in the chat or in the questions box. So one question that had come through, there are different hospitals throughout the country, and some of them have little to no access to this kind of treatment. What kind of advice would you give to patients who are in more rural hospitals who's with no access to this kind of treatment so they can advocate for themselves to get this treatment?
Yeah, that's a great question, because you don't want to go anywhere to get this operation done, and you really want to seek expert places. So one great resource is clinicaltrials.gov. You can reach out there and find a clinical trial, and a lot of places are helpful. And also going through resources such as Debbie's Dream Foundation. I've had several patients referred to me through them with limited access, and they're really great in getting you hooked up with a specialist in this unfortunate problem. And if you just reach out to a lot of hospitals, a lot of cancer centers do have resources for you to either help with lodging, transportation, all of that, to help get you treated and get you the help that you need.
Thank you. And we have another question from Carmita in Florida. When you consider an eligible candidate for CRC HIPEC, do you believe it would be someone with 8 to 12 rounds of effective systemic chemo is a better approach at the peak of effectiveness before resistance, or better longer stability, like 12 rounds of chemo?
So I think that's one of the questions that's really hard, because I prefer to wait and give it a test of time, but you also can't give so much chemo that you're so debilitated from it and get so exhausted. So I think it's really a test of the biology. So I think 8 to 12 rounds is probably the max I would want to see. And then, because I think that tests the biology of the tumor, that we know that it's responding. So then I think it's, at that point, it's consideration of moving towards an approach to treat the peritoneum.
Thank you. And we have a question from Amy in New York. Does a patient need to be off treatment prior to HIPEC, and if so, for how long?
So in general, I like to see patients off systemic chemotherapy for about 6 weeks before proceeding to the operating room. It also depends on the type of chemotherapy you're getting. If immunotherapy is part of your regimen, I'm not as picky about keeping you on the immunotherapy for some time closer to surgery, but I like to get a washout of about 6 weeks of the cytotoxic systemic chemotherapies, like your FOLFOX, your FOLFIRI, or other regimens that you might be getting at the time.
And then we have a question from Carol. I think she wanted to see your email address again.
I don't know how to put that back up, but there you go.
Yeah. Thank you. And a question from Lisa in New Jersey. For most of your statistics, were you talking about intestinal gastric cancer, or I guess it's cut off. Were you talking about intestinal gastric cancer for your statistics?
So generally, for those statistics, it's all comers. It consists of the intestinal and diffuse subtypes of gastric cancer.
Are there any other questions that people might have? I'm just looking at them as they come in. I think so far that is all the questions, and we can also share the email address again to all the participants in the who have come in and watching later. We can also share it again. Making sure I can. All right, so again, we thank Dr. Brown for taking time to do this presentation today. And we also want to thank our generous sponsors, Platinum sponsor, Bristol Myers Squibb. And this program was made possible through an independent grant from Merck and Company Incorporated. And thank you to our silver sponsor, Amgen. I think I had skipped a slide, and sorry about that. To view any of our recorded webinars, please visit our lecture library on the DDF website, and please be sure to see our next few programs coming up. So thank you again for being here. Have a nice day.